Thank you, Dr. Armstrong, for introducing segment one of our three-segment series. Hello, my name is Maritza Molina, and I'm a registered dietitian, and I work alongside Dr. Armstrong and our amazing interdisciplinary wound care team at Keck Medicine of USC in sunny Los Angeles, California. In this section, we will discuss assessment and screening for nutritional deficiencies, as well as take a look at some of the various nutritional goals. Two of the most common mistakes when caring for patients with diabetes is number one, assuming overweight patients are malnourished, and number two, assuming ambulatory patients aren't malnourished, especially geriatric patients. Overweight and ambulatory patients can be malnourished as well. All healthcare providers managing patients with diabetes should develop and implement a formalized nutrition screening and assessment protocol to help identify patients with or at risk of malnutrition. The main goal of screening is early identification of patients at risk of malnutrition. If an initial screening suggests an increased risk of malnutrition, the next step should be a thorough nutrition assessment. Now, let's get into the next section. Screening and assessment tools. There are a variety of clinical validated nutrition screening assessment tools. The typical ones that we do use that are most popular and very common. For screening, this includes a nutritional risk index known as an NRI, and malnutrition universal screening tool known as a MUST. For assessments, there are a patient-centered subject global assessment, which is known as a PGSGA, and the nutrition focused physical assessment, NFPA. The NFPA is typically practiced mainly by registered dietitians most of the time in inpatient settings, but can also be practiced at outpatient settings depending on the time allotted with the patient. And then there is a mini nutritional assessment, which is known as M&A, which spans both screening and assessment. For an outpatient setting, the M&A may be the most efficient one, of course, depending on how much time is allotted with the patient. Select the appropriate tools depending upon the population and available resources at your clinic and or hospital. Each organization may have its own preferred tools. So don't hesitate to reach out to your teammates to determine what tools are best utilized and are effective with the patient population you are working with. Physical examinations and obtaining patient history are key steps in the assessment process. Perhaps the most obvious, checking current weights and plotting weights over time is absolutely critical in establishing nutritional status and identifying risk for malnutrition. Of course, plotting weights, that means most likely catching a patient in an outpatient setting. So every time a patient comes into your clinic, ensure that a patient is actually being weighed. Equally important are patient questionnaires. Specific questions should be asked regarding their eating habits, which will include the fruits, vegetables, carbohydrates, protein intake, and of course asking what the portion size of their food is, that specific food, or even their meals, alongside asking about how many meals per day they're also having to determine adequacy of nutritional components. Some tools can be used to determine appropriate daily nutrition intake. So the most commons are 24-hour recall. 24-hour dietary recall, typically dietitians like to utilize that very often with patients in an outpatient setting to determine what does a full day of nutrition look like to this patient. Most of the time we like to ask they had the day before because that's the most freshest day of food intake to them. Of course, on a day-to-day basis, everyone's food intake will vary, will change. So it's always good to kind of keep that in mind and ask the patient, or what does a typical day for you look like? There's also the meal frequency questionnaires. Most importantly, it's also very important to know determining safe access to food and need for specialized or modified diets. This means, does a patient have swallowing difficulties? Do they have dysphagia? Are they missing their dentures? Are the dentures loose? Or do they have any other kind of underlying gastrointestinal disease that may affect their food intake? So questions like this are very essential to ask, especially at an initial consult with the patient. Also, evaluating socioeconomic status and home dynamics, which means, does a patient live alone? If so, can they cook? Conducting 24-hour recalls and food frequency questionnaires should be practiced at every visit when treating a patient with diabetes to ensure that patient is meeting their estimated caloric needs. Laboratory evaluation. Clearly, since we are working with diabetic patients, we definitely do want to run some lab work. Most importantly, glycated hemoglobin, also known as the HbA1c, should definitely be obtained to determine their diabetes control. So one big question we have to ask ourselves, where is this patient's A1C at? Is it close to 7.0, which means most likely well controlled, potentially, or is their A1C at 12.0? This will give us a really good hint and idea of exactly where they stand. You should also consider one or more of the following, which is total lymphocyte count. It may be a useful index of overall nutritional health, and also checking albumin and prealbumin, which is often ignored as risk factors. However, these are not to be used as sole markers of malnutrition, especially when a patient is undergoing severe inflammation. If the history and physical exam indicate micronutrient deficiency, specific tests may be ordered. Risk factors for ulcer development. During the screening and assessment process, you should be aware of the most significant risk factors for DFU development, which will be medical history, including any previous chronic wounds, age, the greater the age, the greater the risk factor, weight, the greater the weight, the greater the risk factor as well. Validated assessment tools such as the MNA, which we've spoken about, which is very useful in outpatient settings, again, depending on the time allotted. Medications and comorbidities, reviewing all of that. And ability to meet nutrition needs independently. Is the patient able to eat on their own? Can they, just like we talked about socioeconomics, can they actually cook on their own? Proper nutrition is fundamental to healing. When poor nutrition or malnutrition is present, wound healing can be delayed, worsen, or even come to a halt. Wounds require protein, calories, and micronutrients to provide the substrate to support neovascularization, collagen formation, and epithelialization. Nutrition requirements. Hydration. Hydration is essential to healing since it helps regulate body temperature, maintains kidney function, helps deliver nutrients to cells, contributes to good skin vigor, and helps better blood flow, which are all important factors when preventing and or treating a diabetic wound. So what are hydration requirements? It can be 1 ml per kcal or standard maintenance fluid requirements, which are 25 to 35 mLs per kg of body weight per day for healthy adults. While this is a norm, keep in mind patients with heart failure, reduced renal function, or certain medications, and in other scenarios may have very special hydration needs. Calories may be higher than usual when a DFU is present, a diabetic foot ulcer is present. Calories provide energy to aid in wound healing. Energy demand increases with the patient's nutrition risk factors and the severity of wounds. Specific kcal requirements may vary depending on body weight and BMI. Ideally, utilizing indirect calorimetry is a gold standard for identifying energy needs. If indirect calorimetry is not available, there are other formulas that can provide a standard starting point. You can see a breakdown of the kcal recommendations for each range in the following table. Carbohydrates and fats. For patients who have poor glycemic control, carbohydrate requirements will require focused attention throughout treatment. In a patient with elevated BMI and poor diabetes management, one should attempt to minimize energy intake while optimizing protein intake. Of course, this will be based on a case-to-case scenario, so as usual, use your clinical judgment. Only in patients of low BMI will it likely be necessary to set specific minimal caloric goals. However, once again, this is going to vary from patient to patient. Carbohydrate daily recommendations will vary from patient to patient based on the maturity of their type 2 diabetes, daily glycemic control, and if the patient is on insulin therapy or oral hypoglycemics. The average woman needs about 3 to 4 carb choices, which is 45 to 60 grams per meal, while men may need 4 to 5 carb choices, 60 to 75 grams at each meal. This number could vary more or less depending on the individual's caloric needs, i.e. also if they're pregnant, nursing, if they're ill, and if they're taking medications like corticosteroids, or even their level of physical activity. So clearly, carbohydrate intake is going to be catered and it's going to vary from patient to patient, keeping track of their blood sugar levels as well to see how their body responds to specific carbohydrate intake in respects to grams and types. Most carbohydrates are measured in grams, which is 4 kcal per gram of carbohydrate. One carbohydrate choice equals to 15 grams of carbohydrates. Protein intake is essential to provide amino acids for optimized wound healing. These amino acids build and repair muscle, skin tissue, hormones, and enzymes, and help to regulate fluid balance and promote positive nitrogen balance. Increased protein levels have been linked to improved wound healing rates. In addition to quantity, the quality of protein consumed is also important to provide adequate essential amino acids, which cannot be synthesized in the human body. Many guidelines recommend about 1.25 to 1.5 grams a kilogram of body weight per day of protein for malnourished patients with chronic wounds. You can see a breakdown on requirements in Table 6. One study has shown that a combination of these 3 nutrients, arginine, glutamine, and HMB, improves wound healing of DFUs in patients who have poor limb perfusion and or low albumin levels. To tell you a little bit more about them, arginine is a conditional essential amino acid that plays a role in inflammatory processes and collagen synthesis, regulates pathways and requires for tissue cell growth, replication, and repair, and may be beneficial to enhance wound healing. Arginine can become very essential in malnourished patients with DFUs or those at risk of DFUs, and is beneficial in larger doses when a diabetic wound is present, since it has been shown to enhance wound strength and collagen deposition. Glutamine is also a conditional essential nutrient that is vital for wound healing. It is used by cells within wounds for cell proliferation, inflammatory cells, including lymphocytes and macrophages. Hydroxymethylbutyrate, HMB, is a metabolite of leucine, an essential amino acid, and can be acquired through both plant and animal foods such as grapefruit and catfish. Although more studies need to be done to determine the efficacy of HMB, there is current supporting data that reports that HMB has been shown to decrease the proteolysis, increase the protein synthesis, decrease the apoptosis, increase the cell proliferation, stabilize the muscle cell membrane, and modulate protein degradation, which seems like a lot. So the patient would benefit from these 3 supplements. Why not give it a try? There are many micronutrients that are also playing an important role in wound healing, including zinc and vitamins like vitamin A, vitamin B12, vitamin C, vitamin D, and vitamin E. You can see a breakdown for each of those in the following table. Thank you so much for viewing segment 2. I really do hope that you're able to get some really good nutrition information, guidelines, facts, and information that you could overall utilize, tools that you could utilize with your patients at your wound care clinic. We hope you continue on to view the next video segment on nutrition interventions presented by Dr. David Armstrong, my co-author, friend, colleague, and current ALPS president. You can visit the full guidance document at guidelinescentral.com/DFU and visit other resources on the ALPS website. Thank you so much for watching.